Okay. So pancreatic neuroendocrine tumors are different than the so-called carcinoid. Morphologically, under the microscope, they look identical. And honestly, the way you can really differentiate is by a scan. You have a mass in the pancreas. We believe that's pancreatic neuroendocrine tumor. If you don't, most often it's from somewhere extra pancreatic, if you will. So, but clinically, again, they don't, in general, do as well. The overall survival is less than the so-called carcinoid tumors, at least the midgut for sure. But thankfully, we have a lot more sort of treatments to consider. So targeted therapy, as you know, two New England Journal of Medicine papers at the same time, everolimus from the RADIANT-3 and the sunitinib, so unquestionable improvement of progression-free survival. Somatostatin analogs based on the clarinet data have been proven, and cytotoxic therapies work well for pancreatic neuroendocrine tumors as opposed to the carcinoid where there's a much more limited role. So again, how do you sequence these? How do they all come into play? And what do they help us with? So the problem is that with targeted therapy for pancreatic neuroendocrine tumors, the responses are still very low. So objective response rates are still on the order of 10% or less, probably around 6 to 7% for everolimus based on the phase 3 studies. And importantly, with our pancreatic endocrine tumors, often these patients have big burden of disease. So you want a good response in addition to progression-free survival improvement. Again, quality and quantity, and how we can do that very often helps by shrinking the disease, because these patients can be quite symptomatic. So traditionally, streptozotocin was the cytotoxic or alkylating agent that had been used. Now with more modern antiemetic therapies, it's probably much better tolerated, but at the time, it was quite toxic, and then temozolomide came along with capecitabine. But quite frankly, the data is pretty lousy. We all use it because it works pretty well. But in 30 patients in a retrospective review, the objective response rate was 70%. So the big number, 70%, was like, wow, that's pretty amazing. Man, it's a pretty small study. We don't generally drive our clinical care based on one small study. And the median progression-free survival, though, was 1.5 years. The problem is this was first-line comers, all patients. Again, who are we targeting? How do we select them out? That wasn't really considered in this very, very small study. And yes, it was pretty well tolerated in the short term, but boy, alkylating agents, those are big drugs, and we really don't know the long-term toxicities of those either in this patient population that can live for many years. And for many of us that use these drugs, you can start to get into trouble longer term with those blood counts. And again, you want to make sure that you're able to use all the therapies that you would like. And these patients can get portal hypertension, they get embolizations, they have troubles with their counts to begin with. So you have to be a little bit careful on using these cytotoxic therapies and for how long. My general approach in the clinic is I do not use this for longer than 1 year. I stop patients after 1 year because I don't feel comfortable keeping a patient with an alkylating agent on for longer than that. So we actually looked at our experience. So that was, again, 30 patients, all comers. When you look at it and when patients are really progressing in the second and third line setting, there's still nice response rates, but our response by RESIST was about 30%. So again, you still get some great responses, but not surprisingly, in a more progressive patient population, it's not 70%. So could you do anything else? Maybe that's a little safer, maybe with targeted therapies, because single agent targeted therapy is still on the order of 6% response rate. So it turns out the VEGF and mTOR preclinically suggests that maybe they could be synergistic. We know that the PI3 AKT mTOR pathway is important in neuroendocrine tumors, although I would argue we're not exactly sure how or why, but we know it's important. And that the combination may lead to additive or perhaps synergistic effects to block some of the escape mechanisms that we're hoping to define more clearly. So we did a study with Dr. Hobday at the Mayo and through the alliance mechanisms, and we did a multi-center phase 2 study of temsirolimus, which, as many of you know, is IV mTOR inhibitor, essentially the same in terms of the mechanism of action, but didn't make it through, plus Bev in advanced pancreatic NETs. And amazingly, and in a very exciting way, the partial response, based on this phase 2 study, but still, the partial response with 2 targeted agents was 41%. That is a game changer in our disease, where single agent is 6%. So you're adding in Bev to an mTOR, and our response rates went up to 41%, which was pretty great. And those patients, I should note, had real resist progression prior to enrollment. So that was a heavily treated patient population. And then Dr. Kolke and all did a study of everolimus with Bev, again in the phase 2 studies with a partial response of 20%. So again, suggesting that the combination of Bev plus an mTOR inhibitor can increase response rates at least in a single arm, phase 2 study. So Dr. Kolke and the Alliance group then set out to do a randomized phase 2 study of everolimus versus everolimus plus Bev in patients with metastatic or locally advanced pancreatic endocrine tumors. So this was reported at ASCO of last year. Many of you know these patients were allowed to include the octreotide. Both of them could have octreotide in both arms. And it was either everolimus versus everolimus plus Bev as the experimental arm. So it turns out that when you look at any grader 3 or 4, combination therapy, not surprisingly, was much higher in terms of the side effects. It was a little bit surprising that it was so high, but I do caution that the 81%, even though I sort of put this very strong emphasis on that in ASCO last year, 81% is mostly grade 3 hypertension. So for those of us in the clinic, we actually can handle that pretty well. You have to put on some antihypertensives, but it is interesting that the AEs were so high. But interestingly, because of that, many more patients in the combination arm dropped the treatment, and it was probably because of either dose modification or adverse events. So again, this sort of study shows that. So the reason why more patients on the combination arm came off study was probably because of toxicities. And these were the toxicities. Hypertension, infection, interestingly, was 3 times higher, although pretty low still at 6%, and diarrhea was higher. And then again, the expected MI or cardiac arrest, which is rare but serious, was seen on the Bev arm and not on the everolimus arm. But nevertheless, again, the response rate was 31% for 2 targeted agents for pancreatic neuroendocrine tumors. So for targeted agents, combination treatments with an objective response like that, that is a paradigm shift for our disease that we had not seen before. And this is, again, a tumor, I want to emphasize, that really does need some tumor shrinkage for quality of life for our patients because they can have heavy tumor burden. The median PFS was slightly better in the everolimus plus Bev arm as well. Overall survival was about the same. So the take-home message was there were more adverse events on the combination arm, and we have to be careful, back to the quantity and quality thing. But it did have a doubling of, or actually almost 3 times difference in their response rates, and had an improvement of the progression-free survival. So the big question is, where do we go from here? This is a randomized phase 2. This is not a randomized phase 3 study. So there are questions that remain unanswered. What is the optimal duration needed for the combination? Do we even have any markers to bioselect and enrich the patient population? Is sequential therapy just as effective and less toxic? And the reality is the patents on Bev are about to expire in the US in July 2019. So perhaps a biosimilar could take the place of that, but the reality is Bev is not moving forward. And that's pretty powerful data still, so it needs to be considered, I think, more carefully. Can we learn from other diseases? So renal cell carcinoma always tends to do a lot better than us in our clinical trial design, and a little bit always ahead of us. But I think it's a reason for caution because their combination with Bev and mTOR was not better, in fact, more toxic, and that sequential therapy proved to be better in that patient population than the combination. And so what about Bev Single Agent? So as part of our Alliance trial, we also added on an arm to just single agent Bev when we saw that the combination was so impressive. And in fact, again, the patients received single agent Bev, 10 mg per kg. The PFS in this patient population that was progressing by RECIST was 18 months with an objective response, just a single agent Bev, to 14%. And I can tell you a lot of these patients have been on the trial for a long time. It was in 2009, and I just had a patient come off Bev. So it's an anecdote, but it's very exciting that some patients in this phase 2 setting did really well, and the drug is very well tolerated. So outside hypertension, there really weren't grade 3 or 4 toxicities in this single-arm study. And the grade 1, 2 toxicities were what would be expected. So if you put it all together to understand the treatment of pancreatic neuroendocrine tumors, I think appropriate selection and sequencing of the treatments really depends right now on clinical judgment, but needs to be better clarified. Again, this goes back to the careful observation for the low-grade tumors, but with symptomatic high-burden disease, we need to treat them. So targeted agents in combination could be a very exciting way to do so. So 2 targeted agents caused a real objective response rate, Bev being the second one to add on, of 31%, which is a game changer. We need to better clarify this and evaluate in more rigorous phase 3 studies. So all these trials that I've discussed today were multi-institutional, and I thought that this cartoon was really great when the Lincoln and Douglas debate over slavery, and they say, "Where are your flag pins?" Because everybody in the United States has to put their flag pins on. So thank you very much.